Hello and welcome back to the Digital Maturity Forum. I am Sam Shah, I'm the chair of HETT and chairing this session. Well, you're very welcome and congratulations for staying until the end of the day for, of course, what is going to be the best fireside chat closing keynote discussion. So you've probably heard lots about integration, interoperability, sharing of records, all sorts of things. And we've mentioned primary care, social care, and various things. I've certainly heard about the agenda from NHS England, the ambitious plans, the policies around social care and primary care. And that look you just got there is the fear of the questions I might be about to pose. But it gives me great pleasure to welcome two former colleagues and friends, Minal, Bakhai, Mark Nicholas from NHS England. Well, first of all, welcome. Well, we'll get started. First of all, great to see you both. I'll do the nice bit first. I think they used to call this a shit sandwich, but we'll just, you know. So, lovely to see you both.
Middle.
And, of course,
I'm
you
in
both
the
been...
middle.
Well, yeah, you're in the middle. OK, well, you know, we'll go with that. But look, you've both been working on different aspects of the transformation agenda. And we've been talking lots about transformation over the last couple of years. I guess just to start off with, from both your perspectives, from primary care, social care, where would you say the greatest gains in transformation in each of those areas have happened? Minal, how about for you? What's been the biggest transformational change?
So I'm also a GP, as you know, and so a huge advocate for what primary care brings to the NHS and for driving care closer to home. And I think it's no surprise to anyone, demand has gone up. We're seeing 15% more clinical consultations, at least in general practice. Complexity has gone up. A lot of that is being driven by increased need in our elderly or older, more frail population. And then, of course, at the same time, we're seeing a drop in capacity. So we're almost 2,000 GPs down from where we were in 2015. Stress, workload, burnout are the most commonly cited reasons.
So would you say it's almost like driving with one foot on the accelerator and one on the brake at the same time in primary care?
Yeah, absolutely. And so I think the other element to that I'm starting to see in the data is that while we know need is growing, the rate at which activity is growing is slowing down, which means that we might be getting to saturation point, and that is particularly pronounced in the most deprived areas. And I work in a really deprived area, so I actually feel like I experience that every time I'm in clinic. And so we've got this burning platform, and we know that probably things are going to get much worse. So we've got a growing population, 3.4 million growth in the next 15 years, 3.3 million is in the over 70s. And so brilliant, we're living longer, but we're living longer with multimorbidity. The average 80-year-old will have 6 long-term conditions. But at the same time, you know, the economic outlook does not look positive. So our working population is growing by 4%, so the revenue generation for public services, but ill health is growing by 37%. We're almost already at Scandinavian levels of taxation. There doesn't look like there's going to be this big injection of cash, much needed cash, into the NHS. So we do need to work differently, and we need to look at how we better align existing capacity to need. And so that's where I'm seeing the work that we're doing in primary care transformation being really pivotal. And the first step of that is what we've described as modern general practice, but it is the first step towards a journey towards more integrated primary care. And for me, that means we have to look at how we organise our ways of working so that we can provide more inclusive access. We understand the need at the point of contact, so we can better understand the ask on the service. We can then enhance our care navigation underpinned by population health management approach. So we're really accurate with where people need to go, that need to be met, and that's not but just based on anecdote or feeling or subjectivity, but also on data and evidence. and then we can improve the efficiency of our processes using digital technology like messaging. So we looked at 10.5 million patient contacts in practices working this way. 30% could be managed through messaging, through digital appointment booking to give patients more flexibility and convenience, but also to reduce the administrative burden on staff.
And look, you've quite rightly set out an ambitious strategy here of great intentions of what the system want to do. And we should come back to that in a moment, because I guess you've quite rightly highlighted the economic challenge of making this add up. With that, and we hear about it all the time, and Mark, you might be close to this, is the burden that is faced across the system, particularly we hear from social care, where you've got this sort of problem where underinvestment, historic and dated estate, increasing burden of need, and at the same time what feels like sometimes an isolated part of the system. Now you are in NHS England, and previously as was NHS Digital, but from a social care background. What are you seeing as having been the biggest transformation, but where is the biggest need for transformation now?
I think we've got the advantage in this space in social care of kind of occupying an empty land, if you like, because there was, when I started in this job about maybe 7 years ago, there was hardly anything in terms of digital innovation in social care, and over the past 7 years or so, I think things have really improved or progressed at least. So we've got the advantage of starting from scratch and being able to learn from some of the problems that we've had within healthcare. So to be able to, where things have not gone according to plan, we've been able to learn from that and be able to plan around it. So that's an advantage. The disadvantage is we have been starting from scratch, and getting the infrastructure right is the bit that we really felt that we needed to focus on.
And do you feel that on that infrastructure side with social care, do you feel there have been great inroads, any major changes that have taken place both this year and the last couple of years that you can sort of point to?
Yeah, I mean, within the last few years, the investment that we made in digital infrastructure, so for example, with digital social care records, a couple of years ago there were barely 40% of social care providers, so that's the residential nursing and domiciliary care providers, had a digital social care record. Now we're over 60%. The intention is that we get to 80% by April next year. So just being able to make that investment in that infrastructure over a period of time. And you've got to remember, social care is huge. So there's 26,000 different organisations that we're talking about providing that infrastructure for. We're in a position where we've got 152 local authorities, for example, to be able to link into that. So making a change from 40% to 60% in 2-3 years or so, I think is a really big step forward, and something that we can be proud of, really. But it can't stop there, and we need the investment to be able to take it further.
Well, look, you both referenced some, various statistics around both the problems in the system, but also the progress in the system. How about the other piece, the integration between the two? We speak to colleagues, I'm sure we all do, out there in the system, and one of the challenges is I hear from colleagues in social care, which is, well, if only I had visibility of X, Y, or Z, I could do such and such that would stop a patient being referred. Equally, colleagues in primary care that almost wish that actually if somebody in social care picked something up earlier, that they might be able to make a decision without referral back to a GP or asking for a domiciliary visit. Where's the integration between the two that would at least transform the model of care? Does it exist? How do we get there?
So, I mean, from some of the work that we've been doing, so we've been testing something called Improvement Week. And what that means is we get all system partners round the table in a practice. So that's social care, mental health, the acute trust, ambulance service, patients, communities, the voluntary sector. Yeah, get everybody around the table. And a practice opens its doors to all of those individuals. And for a whole week, we look at every single bit of workload that hits the practice, because we know that 93% of first contact is with general practice. And we examine each of those bits of contact. So the practice will say whether they felt it was appropriate for general practice, whether it could been better dealt with by another service, it didn't need healthcare at all, etc. And you've got everybody in the room starting to build an understanding of the need, of the demand and of the need. Secondly, you're starting to build those relationships. You're using data to move away from anecdote to actual evidence-driven kind of understanding of the problem and therefore the solutions. And then there are four actions. Either the practice can make an improvement there and then into their own process. The practice can make an improvement, but it's going to take a little bit longer. The system can make an improvement there and then, or the system commits to making an improvement, but that will take a little bit longer. And the system partners commit to making that improvement. And what we've seen is that up to about 18% of work so we looked at 33,000 different data points, 18% of that could have been directed to a more appropriate service or person, and 29% of that was what we would class as an inappropriate transfer of work. And what's really important about that is that it starts to build not just the transactional bits that you need, or the infrastructure bits to drive some of that change, failure demand essentially across the system, but it also starts to build the leadership, the culture, and the kind of vision, shared vision about why this is important to do, because the patient is at the heart of that.
And in this model, and I often hear about this, that's all well and good, and it's great that we have this approach of teams coming together, primary care networks working a different way, system working. The pushback I often hear about is, well, who's going to pay for it? Where's the resource going to come from? Is that a real challenge for primary care practices and systems that are on the ground?
So I think resource.
I can't hear that one, can I? Can you? How strange.
Is that working? Is that working? Yeah, great. So I think resource is a problem, but I think even doing this work, it identifies where we're using resource inefficiently. So there's lots of duplication of work, and I think there's opportunities to use the resource that we do have better. That doesn't mean we don't need more resource, but I do think that we can be more efficient as a system if we examined our system-wide processes, but bring everybody together around that shared goal, around improving the journey for patients. But what you also need is strong system connectors and essentially an SRO at system level to kind of follow the process through. But where we've seen that happen, and you've got really built the why with the stakeholders, you've used the data, and you've started to take people on that journey and empower them. So you're not just doing the work for them, you're showing them how it's done and then empowering them to continue and do that work for themselves, has been incredibly insightful and very productive.
And with that, Mark, I mean, look, you've got a situation here where you've got lots of willing system partners, but a cash-strapped system. And social care is often seen as sort of the poor cousin, the Cinderella of the health and social care system, not really inside the NHS, but with stakeholders in the NHS. Who is it and where is it that social care colleagues should look for investment in the infrastructure to make this change happen, to bring about the sort of scheme that Minal just described?
Well, I think the really interesting bits of integration are happening at a local level. To say that first of all, we should be supporting it from a central perspective, but the really interesting stuff and the relevant stuff is happening at a local level. So, integrated care systems provide a vehicle not just for collaboration and integration, but also for investment as well. And I know that anybody from an ICS might argue with that, but they do in reality. From a central perspective, it's very difficult for us to be able to address individual concerns. What we do need to be doing is making sure that we've got our ears open to what those local needs are, and being able to kind of collect them and be able to do something with them collectively. So, for example, around information standards, So we listening to PRSB talking earlier on about the core information standard, which we fed into from a social care point of view, and which now some suppliers are using in terms of being able to construct their systems that they intend to use across both health and social care.
And for the sort of remaining term, I suppose, of this government as exists and the mandate on NHS England, what are the big programs that are solving those social care needs? What are the programs that, from a digital transformation perspective, that you and colleagues are working on that would solve for some of those needs? And I guess for members here, things they might want to get involved in.
Yeah, and they're things mainly that are starting from that position where we're just slightly above scratch. I talked about starting from scratch. So, things around making sure that we get to that 80% target for social care providers, because what that means then is that we can start to flow data. We've already achieved a position where we're starting to flow fairly basic data set from local authorities, client level, what we would call client level data, which is a live data set which is flowing into NHS England from local authorities. We need to be able to do the same from social care providers in residential nursing and domiciliary care. Once we've got that data, we can start to analyse those journeys across the system and make sure that the kind of optimum services are being provided to the patient. Similarly with workforce, what are we doing around workforce that can help things to be able to join together? So very, very difficult to recruit and retain people within the social care workforce. But we could use digital as a way of being able to provide some kind of a skills ladder for people within that social care workforce, which can then in turn benefit both social care and health, because those people can be used and can progress a career within both. So areas like that, I won't go. There are 5 key areas really, which I know we're running short of time, so I won't go through them all. But there are 5 key areas where we feel that we need to make some progress in order to be able to address that challenge of digital integration.
So final thoughts from both of you. Accepting that none of us here can really determine the future policy, and that's for a future government to solve. But if you had a wish list, what would you like to see as the model of health and really primary care and social care integration? What would that model look like on your wish list for a future government and set of policymakers? What's the ideal? Final thoughts, Minal?
So for me, I think it's absolutely investing in care closer to home. That's what patients want. That is, the right place to be able to provide high quality care, that continuity of care that is so important. So for me, I think, also taking a pragmatic view on what is deliverable, I think being able to have that inclusive access, so people can access and have choice in how they access services, to be able to segment the population using a population health management approach and really understand where the right place of care is first time for those individuals, to be able to provide care flexibly and again tailored to that to the population and to that individual's needs. A more personalised approach is going to be really, really important, but not just thinking about unscheduled care or reactive care, but applying that to scheduled demand so that you can start to prioritise health reviews for your higher risk patients before winter, to give you more winter resilience. But also to reduce unplanned admissions, A&E admissions, reduce bed days that we've seen when you implement this properly. But also for me, where I work in a really, really deprived area, give me the headspace to do the proactive care that really matters. So my high-risk patients that haven't consulted with me for over a year, the patients that are over 50 that have not attended the practice or contacted the practice for 5 years, when we go out proactively and find those communities, it's not because they're well, it is because they've not prioritised healthcare because of all of the other social determinants of health. And so to be able to go out, build those relationships, and to that time that's needed to build those relationships to be valued. It might not be an appointment, but it is absolutely critical, valuable time that then helps build the trust and relationships to engage those communities and start levelling up and reducing health inequalities, and that is what really, really matters, I think, to me and for the population that I serve. Absolutely.
So a proactive approach, which is risk-based, that really helps prevent that sequelae of illness downstream.
Yes, the prevention.
Mark, how about yourself?
I'd like to see some progress in terms of truly shared health and care records across the system. So, you know, there's been a lot of work done in that area, but we still hit the same old problems with, you know, who's a registered professional. So social workers and occupational therapists are registered professionals. Registered managers of care homes have a, you know, they could be considered to be part of a role-based access control arrangement. So I would like to see some real progress with those shared records, perhaps around the core information standard that I mentioned earlier on. I think if we could do that, and we could start to be able to share information for direct care, first of all, because that's the important bit, but then also to be able to share the data that's generated from that to be able to improve patient and citizen care.
Well, thank you both for painting a picture of what the integrated social and primary care interface could look like in the future. Thanks for sharing your thoughts and for your authenticity. And please join me in thanking Mark Nicholas and Dr. Minal Bakhai. 2024. Thank you so much for joining me. Thank you for coming today, for participating, and for all your questions and thoughts. It's been a pleasure. Join us again for HETT South down in London in a couple of months' time. Thank you.